right, thank you for the opportunity to be here, and as was mentioned earlier, to stay here that long. And I see there's some concentration there, which is great. That means that if I look at you, it's like, oh yeah, I have a big audience, but it's actually a lot of people for today. So I appreciate everyone's being here, and something that I also want to say to organizers: this is like a very good meeting. Like it's like almost like a hidden jewel, because it's very hard to get this quality of speakers. I mean, I'm not putting myself there just to like, so, but the folks who are coming in, I mean, just have a chance to talk about integrative oncology or the results of the challenge trial. Those are like in Dr. Pigram, who I trained under him years ago when we were at University of Miami. It's really a very good meeting, so I appreciate the invite and humble and honored to be here. So that being said, let's get started and talk about the topic of the day, right? AI in oncology. What's new? What's the different thing? And as Dr. Flores was mentioning, this is an evolving field. And every single day there's a new algorithm, there's a new FDA approval under the different pathways and whatnot. So the idea today is to have an overview of kind of like visionary to some extent, because you cannot implement all the solutions at once. But you can pick and choose whatever piques your interest on the things that you really want to be in oncology and integration with AI. And for those who want to follow me, I'm Twitter or X, how you call it. I'm Dr. Arturo AI, so it's easy to find me, right? So, and also do things in LinkedIn and whatnot. So let's get started. So over the last couple of decades, we have seen what we call a Cambrian explosion based on two major aspects. The first one is the data side, right? So we now have the ability to collect tons of information from the electronic medical records just because of mandates that we do for billing. But that brought an opportunity to get a ton of information that we didn't have before. It was all like scraped notes and whatnot. And on top of that, we had the era of genomics. We not only have next generation sequencing, but we have all these other omics like proteomics, epigenomics, and whatnot that is continuing to emerge and change. And on top of that, the knowledge is becoming extremely hard to keep up with, right? So even for folks who we all guard, we were like encyclopedic knowledge, like who knows the most. That doesn't really apply anymore. And what we're trying to do now is where to search the right information, right? Because the knowledge is so exponentially changing that even with these meetings, we have to have a meeting every year, right? Because it's just hard to keep up with everything. And when we think about the techniques, right, we have immunohistochemistry, we have RNA assessments, we now have FISH and NGS that now is extremely affordable, right? So even though we hear all these different companies doing different things, all of them have running on the same Illumina machines, and they'll just have different models and ways to tag that information. But it's just becoming commoditized, and people have their own panels at home. They have some other things we can do. We can run a whole, genome panel in our kitchen now. So we don't need to do anything. That's why even in Europe, that's why commercial folks who we see here, they're not in Europe, because in Europe, they just buy the machine and run the test. And that's how they get that. And it's like a $200 to €200 test. And those technologies are getting faster too. There's a few things happening on that space. And we know for a fact that every cancer patient in the advanced setting should be profiled at least once, right? Because I want to know for myself, do I have any, random NTRK fusion that may actually help me, or MSI high or TMB, and on top of that, the evolution of things. In this circle here, I don't want to miss it, is just over the last decade, the amount of drugs or medications approved by the FDA by mechanism of action and by disease type. So each one of those green circles is a cancer type, and all the things that are expanding upon that are all these different drugs that are approved, and that's just a ton. And look at that, every year we get more and more. Much information is changing, and it's also because the design of trials is changing. So we have umbrella trials, we have basket trials, we have the combo match, we have the ASCO taper, which is looking for a main PI. Maybe someone in the family will come and become the ASCO taper. Just throwing someone there to do help with that, precision medicine. But we have a lot of new drugs coming up because of these basket trials and umbrella trials. And And it's not only in oncology, in hematology as well. So one example, the MyeloMatch just came up, which is AML MDS, and they have different designs and all based on biomarkers. And we all participate either through all the cooperative groups or in the the other NCORP as well that we do as well for the community setting. So this is not going to stop. And just last piece of complexity, dynamic changes, right? So we're not just talking about a static point for the patient's journey or when we see the patient, but now we are assessing in real time what's happening in the bloodstream and beyond. So it's not just about having the genomics at that moment, but is there any changes on the amount of DNA that is happening, the amount of RNA we're using now for surveillance, for monitoring, for finding treatment options, and we are assessing also at the time of progression if there's any emerging biomarker that justifies the need to change the drugs that we're going to use for those patients. And a lot of clinical trials have that as well on the hematology and the oncology aspect. So as we add on this additional layer of time drift, it's just becoming untenable. And that's why AI can help us. So of course, this is not a one and all solution, but that's just kind of give you like a little bit of a preamble of how this can potentially help us be a little bit better. So AI is not a new term. Interestingly, it was coined in 1956 by all these gentlemen there. They thought it was a summer project. They called it Dartmouth Summer Project for Artificial Intelligence. And of course, more than a summer took place for that, and took 2 winters of AI before we actually are in the era where we are now. And that is because the, even though in 1956 it just defined it as the ability of a machine to help us to run analytics or thought processing that is similar to humans. There were a lot of pieces of ideas that were nice, but we didn't have the tools to really make them effective. One of them is data, right? So a ton of data that we needed to collect that to make sure that it was not just fit into one tiny space. And on top of that, the ability to use computing power, because we didn't have that. Like in 1950s, we have these big crazy machines that people just do like punch holes and stuff. That was not helpful. Now we have GPUs. That are able to run mathematical equations that will take the known history of the universe in a single second, right? So that's the difference that's happening. And just to give you a background of that, from 1764 all the way down to, this is 2018, but of course we're in 2025 now. I had to create a new timeline for that. But it started with the Bayes theorem and Ada Lovelace trying to look for an algorithm. So she was the first computer programming, quote unquote, that's what they say. That she was working on an algorithm on an intelligent machine by Charles Bragg. So after that, George Boole came with the zeros and one, right? So this is not a new thing. The matrix thing coming down, the zeros and ones come all the way from 1847. And the technology was used for the United States Census because it was taking 8 years to process all the data. So to the point that the census was every 10 years, if we grow a little bit more in population, we won't be able to keep up. So they had to use this Boolean logic to be able to come along with a plan, and that was effective, and that's how we started running censuses after that. Later on, the Turing test came up. So Alan Turing solved the question, is that, well, we can create an intelligent machine or an AI algorithm if it's able to fool us to believe they're human. And now the large language models have actually accomplished that, so now we're past that Turing test. And later on, Jeff Hinton came with the topic of deep learning, and which is a much more robust way to think about, like, if it was the brain, and those little neurons called perceptrons, now they're put into layers, and later AlphaFold and Google and all this stuff came up with technologies to solve, defeat us in different things, say like the Go game and beyond, and now AlphaFold came in place. So, what is AI, and mostly generative AI? Because AI, once again, is not new. What is most recent is generative AI, which is the ability of these machine learning algorithms, which is able to run queries for us and solve problems, usually unsupervised. It's based on 3 components that are listed there in that circle. So the first one is the transformer architecture, which is just a way that the algorithm is run, and I'll show you in a second, based on the attention mechanisms. The other one is data, which means we need tons of data. And lastly is prompt engineering, asking the right questions so you get the right answers to what you're looking for. And generative AI came from that concept of generation of any kind of knowledge based on the query. So you can get images, you can generate text, you can generate video, you can generate now multimodal assessments, and that's what the GPT from generative pre-trained transformer. So transformer technology that generates and is pre-trained because you put a ton of data into them. That's the core basis of all these things that we're doing right now, and it's all based on these GPUs, which is these graphic things that NVIDIA now built initially for video games, and but they were running an equation to render images when you were playing, Mario or whatever. They just decided to change that and create a new software called CUDA that adjusted that in that GPU into being able to run mathematical equations for many other use cases, and they just commoditized it, and now you can use it for many things beyond just video games. Because that's how it started. Like NVIDIA is like Envy, and it was all based on like video games and Foxtrot and like shooting things. But now it's doing proteomics and genomics and robotics and quantum technologies. So with the same tools. So this is the architecture of the transformers, and it's also another nerd thing. Remember the transformers that's the same. It is because these folks actually working in a project called the Autobots before. And the Autobots say, oh, they're transformers, and that's why they gave the name to this. That was never published officially by a peer-reviewed journal. It's available in archive, and it's called Attention is All You Need. And it's all focused on the attention mechanism, which is the ability of this architecture to look at things as the same way as we are predicting the next token. So all these generative AI issues are just the predictability on a probabilistic manner of what's the next thing that's coming up. So the same way you're doing a video game, and then you're going to get the next image because you're moving to the right side and you see what's going to see on that side. The same happens on images or on words. Is the next token, the next feature, and give you the highest probability of that based on a ton of data that you get in before, so it has a ton of examples to learn from. So you went to medical school and they ask a specific question, and if that question is asked often and everyone knows about that, you probably know the answer right away. The same way we memorize things in Jeopardy, in the same way that we do all these things for daily living. This is the same way it happens. So the attention mechanism is giving you a probability, and mathematically gives you the equation results. That's why they won the Nobel Prize 2024 now. For physics, that was Jeff Hinton, which is the father of AI, and Joe Hopfield. And it's just to emulate those inputs with all those layers, and they interconnect with each other through this process called backpropagation, which is mathematically just basically gives you the information. You just make a query, and at the end gives you the output, and then you make a reinforcement mechanism saying, no, that's wrong, or that's right, and then the system learns. And that's how you get the highest probability for the next time around, and that's how you train the system and make the inference. And this is helping us a lot. That's why all these things are becoming, it passed the USMLE and passed the NCLEX. So of course, if you have an open book and eternal time, anyone can answer any question. What is that so dramatic about it? Yeah, if you give me an open book, any of us can do it, right? That's why, like now, when we have the ABIM sitting down every 3 months, they give us 4 minutes so we can go and look at the answer and then just click pass, right? So at least you learn something, at least doing the process of going through the answers. But now it's able to pass all these different tests, and it's helping us to be more efficient. The first use of AI that everyone's talking about is, and said, do you use AI? Is yeah, sure. Why? Because we use an ambient scribes, everyone. So the first one is all these different tools that are being leveraged. Epic has one, Ambient, Abridge, all these different companies doing the same. And it's just helping us to be a little bit better in our cancer care of patients. The first issue that we have is the structuring of information, because we had so much information coming our way. So now we're trying to use these AI tools to make us structure information so we don't have to spend the time documenting. So it's helping us with coding. It's helping us to organize information for registries. And this is an algorithm, for example, called Coral, which is using optical character recognition and natural language processing plus Gen AI, so we can extract information in real time and help us to translate all this noise and information into nodes, and that's the background of how ambient AI works. But of course, we want to make it multimodal. So it has to be just not lab data and nodes, but it has to be also genomics data, monitoring data, and anything in between on top of medical images, so we can make a multimodal foundational model. And that's what the future is coming for these things, so we can make decisions. But now, how does it work for images, for example? Because this thing is giving you a probability, but it's also hallucinating. That's why many times you ask a random question and it hallucinates and just gives you what you want to hear. Or the wrong answer just makes up a citation just out of thin air. Because if it doesn't know the answer, it just simply gives you something that looks the same, and then we believe it. that's the Turing test passing. So for things like imaging and for radiology, there are algorithms called convolutional neural networks, which are basically more focused on locality. It means that we can run it locally. It doesn't really have any generative component. It's all based on ground truth, based on reality, just real examples, real probabilities, and if you don't know, you don't know. In this case, we have these, kernels. We divide the image of a CAT scan into different, squares, and then we do this assessment of as if it was the same as like we mentioned the perceptron, like putting all these layers, all those little buckets, and run it as a neuron, and then we give them feedback. And then it will tell you if it's a granuloma, if it's malignant, if it's normal, all that based on this probability change on this. And we can do the same for images beyond that. So for example, in fundoscopy, we can do it as well. So we just do the same layer, but with 3 different colors. We do red, blue, and green, RBG, and then we just combine them all, and then mathematically get the results. If you look at an X-ray, this is how it looks mathematically. So it's like, okay, I don't understand how these models work. Well, because it's not that difficult. They just simply go from 0 to 256 bits, and they give a number to each one of those densities. So you can see at the bottom when it's more white, is more towards the higher up in the numbers, 140 or whatnot. So let's say you have 140 here, but you also have it here where the area should be a lower number because there's density. That's probably a nodule there, and maybe you should just go there and look at it, right? So that's how these things work. So applications. First, and I know I'm going kind of fast, and still 10 minutes, so I'm going to try to pace myself as much as I can because there's so much information to give. But bear with me, and of course, happy to answer questions later. But just, I'm just throwing you fire here. So one is the dermatology. So there's a shortage of dermatologists. We cannot get them on call on a weekend. Try to get one now to go and see a patient in the hospital. It's going to be super hard unless it's Stephen Johnson's, right? They're in the emergency department. So how can we use these, cameras that we have in our cell phones to give us, maybe help us to triage patients who may be seen earlier by dermatology? So this group of dermatologists at Stanford, 21 of them, they came together and they trained the system with about 1.41 million images. And they were successful in showing the algorithm was equivalent to those 21 board-certified dermatologists to at least assess the lesions. Of course, they're not going to remove it. They're going to do the punch biopsy. But at least you can know who can be prioritized to be seen earlier based on this. Also happens with colonoscopies. So we have now a camera algorithm that we attach to the camera of the colonoscope, and is not only able to find more areas of interest that should be biopsied, but is also and by 3% depending on what you're looking at, and is decreasing incidence and mortality based on a very large cohort of patients. But also is cost effective. It reduced by $57 every time you do a colonoscopy. There's some studies also about de-skilling, so that's the important thing. We don't want to become completely automation biased or algorithm concordant. Because what happens is over time we rely on this too much that then we start to become dependent or de-skilled. So there was a study already showing that some of these folks using these algorithms, when they do it without it, they're not as good as they used to be. So we need to keep up to being humans all the time, right? That's part of the whole discussion. We use this as well for imaging, so because an academic radiologist has to review an image every 3 to 4 seconds just to keep up. And that's what we use Nighthawks and all that. So I always put this image for folks who have not been in my lectures, but has anyone seen something weird here in this panel, A versus B? Like particularly in the A? Anyone can raise their hands, you don't know? Okay. So, I mean, I'm gonna try to show it, but I don't have a finger here. Average, right? So as I'm so focused on this lecture today, right now, there could be a ton of mice behind me trying to eat me, and I'm not looking at that because I'm just focused on you. That happens with radiologists and with anyone else. We average in our brains. We focus our attention to specific things in front of us. And that's happening here. In this case, they were looking for nodules. They never think about, I'm going to look for a gorilla. So 82% of radiologists looking at this image miss the gorilla, even though their eyes put their sight in that gorilla. That's where the blue dots are. That's all the places where the eyes were looking into. So the brain told them, hey, by the way, there's something there, but we were like, forget about it. I'm just going to focus on the rest. That's how our brains work. The same happens with this algorithm. So can we use AI to help us to be more efficient and better and find those things that we typically don't really focus more? So there's a number of algorithms happening. So that this is a single shot. Single shot means you train it and try one time. In zero shot, it means you just throw the algorithm and you ask the query without any additional training. This is a single shot. You tried it once and train it, and it was able to find 30% more, lung cancer compared to the standard, approaches. And there's many more. Mammograms is becoming also one important component for cancer screening. So in this case, I'm not a mammogram reader. Radiologists do that for me, thankfully. But you can see the green spots here supposedly benign, and this is an inflammatory breast cancer, so I don't know. And you can see at the areas of redness or kind of red heat map, those are malignant areas. But if you look at me, it's completely indiscernible to me. I cannot tell you, but the algorithm is able to tell you that. And this is proven already by a randomized clinical trial. It's called the MSEd clinical trial. It was published in the Lancet Oncology, where about 80,000 women were put through the algorithm either to do AI integrated mammography versus conventional mammography, and found that it actually decreased by 44.3% the reduction for second readout. So basically, it was the equivalent of having another radiologist doing the double review. And didn't, or in the half amount of the time. So this is, of course, happening in the EU. We are running now a trial, not me, but there's a study of 6 cancer centers doing it now in the United States, so we can be contextual to the breast densities and the population that we're serving. So the algorithm actually is consistent with our population. But this is coming. We're going to hopefully help more patients to find, really they need. A biopsy or whatnot, particularly as we have increased the amount of patients who need to be screened for mammograms. Close to my heart is pancreas cancer. We really don't have a good tool to really screen patients even at high risk. So there's a number of algorithms happening as well, where we're trying to find with just CAT scans and radiomics what patients are really having a risk for pancreatic cancer. And this is just one of those examples as well. So more to follow for this one. But this is a very large validation tool. It was about 4,000 patients. Another interesting one is this one that was just published. This is how with just the eye exam, and you can predict if a patient is going to have leukemia or myeloma. It seems to be that there is the protein changes that happen as part of these hematological processes. They have a direct interaction in the blood vessels of the eyes that is completely impossible for us to discern as humans, but the algorithm is able to detect them. So now we were able to do what's called the red hemo. This is done by the group of Emory, and was actually able to prove just shoot a shot. You simply put the algorithm, put a patient there, and they say you have myeloma. It is an easy thing to do. You don't need bone marrow biopsies, right? So you simply put your eyes in a camera, run the algorithm, and get the results. I think this is the future of medicine for many things, particularly for hematological malignancies. And we know this is unique for leukemia, lymphoma, and myeloma. We know there's something happening in the eyes for those patients. We're using this as well for segmentation and looking for radiation oncology and for neurosurgery. This is Friends of Cancer Research are trying to use that for RECIST criteria. So we know it's hard for research and all that to spend a lot of time and there's some variability across how we assess for progression of disease. Now there's a national effort to redefine this by using AI, because we have the same tools now. Let's use them for something meaningful to help our research teams. Radiation is doing it as well. There's a number of algorithms able to, instead of spending hours or days doing planning, they can do it in actually a few minutes. This is an effort in the University of Toronto, where an AI tool was able to do in literally 20 minutes the work of 5 days of a whole team for just getting a plan for patients with lung cancer. Machine learning and microbiome is also part of that. So we do a lot of screening these days with different technologies in the fecal test, blood test, but how we can use this to find the signatures on the microbiome. And one example is here. We're having these 7 different bacterium in our colon, and this is from actually validated across multiple different populations. They were able to predict with 99% percentile that actually patients have colon cancer. So what if we add on the, these, DNA testing that we do, methylomes. On top of that, we add on, the microbiome. That can be much more effective. We use this as well for cell classification. So the same tool we're talking about, we just divide it into all these things and come up and give us the classification of the kind of cell that we're looking into. And that led to digital pathology. So we can use the same technologies to assess what cells are malignant versus benign versus microenvironment. And the NIH and NCI and others are doing this, and on top of other different companies doing so. But this is how this is done. This take a picture of the whole slide. It's called whole slide imaging. And they, then you do labeling. And based on this attention mechanism to determine what cells you want to look into. Why? Because pathologies are hard to find. They're actually less and less every single year. The same happens with all different, different specialties, but happens also in low, medium income countries and counties. So can we do that to help the world to overcome these issues? So digital pathology has really made now in NCCN guidelines, we have one algorithm for prostate cancer. That means there's going to be more coming up. And a number of companies doing that as well, so stay tuned for it. And just one interesting example that seems counterintuitive. So in this case, this is entropy theory, can calculate the ability of the collagen fibers in a tissue to predict survival. So in this case, if you have a lot of collagen fibers in a different direction, they're all like disheveled, you have longer disease-free survival in breast cancer. So it has nothing to do with the cells. It has nothing to do with the immune cells. Just the collagen fiber distribution is able to tell you the patient's going to live longer on treatment. So this is just something that's completely emerging category of things that we were never familiar before, and proven by this large cohort of patients. We can look for PD-L1, for example, in unstained slides, so we can spare the tissue or know where to do the biopsies. And now, more recently, radiomics can predict responses to treatment. So you look at these images here, completely impossible for us to tell. This is just looks like a regular CAT scan, but it can tell us what patients respond based on this to CDK4/6 inhibitors with breast cancer, right? So it's not just DNA, it's just, we just look at the radiomics, look at the algorithm, it's able to tell us that. And it's also happening in non-small cell lung cancer for patients who are going to respond or not to immune therapy following chemoradiation in a stage 3 non-small cell lung cancer. And this is an effect noted regardless of PD-L1 status. So they even looked into that. And it was just the algorithm telling you there's this population of patients responding versus the others. And lastly, on this radiomic side, the way how the vessels align also tells you the responses. This is like pipes, right? So you have a straight line to the place, then the fireman can go on and stop the fire. When things are convoluted and they get lost doing that, the same happens with the chemo and the immune system, is happening for this. So these quantitative tumor-associated vasculature responses, the straighter the vessels, the better you get outcomes in terms of treatments. And that has been proven in a non-small cell lung cancer model and in a breast cancer model. And you can see the images here, like how the recurrences are just based on the straight of the lines. So the future is multimodal. I know it says out of time, so one more minute and I'll finish. The future is combining not only the data that we have on the clinical side, but also on the genomics and put it into a single model that is able to, to predict, like, with multimodal neural networks, how we can get the best outcomes of this. And there's a number of models on this where we're combining doing this personally as well, my, collecting all this information and putting it into algorithms to predict when the patient is going to recur, so we can offer them a clinical trial, for example, in real time. This in the case is also to offer the patient, we also have the mammogram, the MammaPrint testing versus the Oncotype DX, what are those things that we can use these tools to really solve the question, should we offer this patient chemo or not, or should we not do it because we have enough data to prove it. So that is what it's trying to do. And And the dream is this artificial general intelligence. What is that? It means a hypothetical type of intelligence that is able to do all the things that we human value as meaningful in terms of work. And to me, I don't think for oncology we need an AGI. We need multiple agents that are experts at doing something the same way we do at our tumor board. We have a ton of smart people. Our brains are better than any GPU cluster you can tell in the world in terms of connections. And we still meet together and have discussions about a single patient with all the knowledge and years that we have trained. So I don't think we're going to have an AGI that's going to be able to solve it all for everyone. We're going to have an orchestrator of multiple agents that are able to solve the pathology question, the genomics question, the immunotherapy question, the microenvironment question, and then come along with a really definitive algorithm that is going to help the patient being personalized. But the future is bright. We have a lot of breakthroughs, which I will breeze through them because of the time, effort. I think we're good, but I don't know how much time we have. Okay. Yeah, so I don't want to rush it because this is also important to show you the future. So this is AlphaFold, which is the Google DeepMind's effort that Demis Hassabis, who now works, he won the Nobel Prize of last year for medicine, was developing. So he said, well, we can play a game of Go. It has a ton of different permutations. There is this problem called the Levi-Strauss paradox, which is the ability for us to predict the structure of a protein based on the amino acids sequence. In nature, even if you have that knowledge, the proteins fold within milliseconds, and it depends on where you are in the universe, right? So you have gravity or not, all those changes happen, but we have the data from many years, and researchers from across the country and the world that they had the repository of each protein structure and how it folded and the electrical changes. So they put all that into an algorithm and run it through GPUs and start to see if they can run these analysis. And they were able to solve this paradox that said that just to solve one protein, it would take the age of the known universe. Now they can do it for any protein levels. And the ground truth, which is the reality, is now overlapping with the predictability of this model. And that was the AlphaFold 2, now this AlphaFold 3, and is publicly available. So anyone can use it and even create new proteins and things that we didn't even know existed, and it's open source. So there's an opportunity now to start looking at, drug discovery. Can we use that now to not only predict the structure of 3D proteins, but also the point where they go for those tough to find KRAS mutations that we don't know how to target, using these diffusion transformers as well. So several companies are doing so with all these repositories of taking pictures in real time of different perturbations. It's called the large perturbation models, where you have all these cells that you take pictures of every single organelle, and you give it an intervention X, and you take a picture of it and see what happens. And then you just do with the next one, and the next one, and the next one. And that's how we are building these bigger foundational models for predictability. So a few clinical trials are happening because of this. Just an example that it took, instead of 42 months, 18 months to find one or 3 molecules that were actually eligible for this specific clinical trial. And just last year, we have a couple of these drugs in this now on the clinical trials. So more to follow for sure. Yesterday, we heard from BioHub, from Zuckerberg and the team at Meta. They're doing all the philanthropy now, focused on AI with the BioHub, and they're trying to create this virtual cell, which is to emulate every single one of those things in dynamic approaches. So we're going to learn more from this. But we need to do it ethically. We need to make sure that there's a human in the loop, that we understand all this is happening, and also understand there's things that we cannot measure, so we need to have a machine that it's aligned with humanistic approaches to measure what that other machine is doing. Because if we put a human to review an algorithm that we don't even see, it's going to be impossible to discern. So we need to have machine checking machine, and we overseeing those two. And that's how the future is going to be on the ethics side. And we presented some of this information in ASCO, so particularly around precision oncology and genomics. We have so many things happening in a single day that we are really still not getting the amount of information that we need for every single cancer patient that we have in front of us. Not only for clinical trials and beyond, but just an example of things I've been doing. 12 million patients over the last decade, 0.1% actually were offered enrolled in a clinical trial. And we have 19,000 plus clinical trials every single year, but half of them close to accrual. Why? It makes no sense. That means that there's a missing point here. So this is all because of this data drift. As we change, we're humans and we evolve. The same happens with the ecosystem around us and the exposome. So the trial opens and closes. We change locations. There's a new FDA approval. So all that accounts for a lot of different changes that we have to be mindful of. And we have opportunity because there's a lot of places that we can deliver care at the point of care, but we don't really have the tool to surface those patients in real time. And AI can help us to match patients. So we did 5,000 patients, and it took 19,500 hours in theory, bless you, versus 1 hour, right? So the idea is to make this as a pre-screening hub. Patients enter the hub and can follow throughout the cancer journey, like an Amazon, Uber, Instacart, but for clinical trials and other use cases. And we have been lucky and fortunate to work with the American Cancer Society to use these algorithms to now leverage it nationally. We did an 8-month pilot, and now is national as of the last week, so this is a new announcement. We are working for any cancer patient in the United States who needs clinical trial help locally, internally, and beyond, fully free to any patient and provider to offer this option. It not only has an AI tool, but it also gives all the power of the American Cancer Society to give them back logistics, Hope Lodge, financial assistance. So we, as physicians, spend more time taking care of the patient, and the patient can be fully empowered, but we don't have to be concerned about anything regarding clinical trials and whatnot. So this is a very good use case of AI that I would love to see further. And in this example will be, we can look for appropriate, medications that the patient is getting, whatever is missing in theirs for adherence. Just-in-time digital engagement, we can do it for foundational models that are bigger, and we can adjust clinical trials so the patients can be treated at home that get their gemcitabine and nab-paclitaxel as part of the standard of care, but they can get the targeted drug across the street with our colleagues, and we're not competing for that patient, but the patient is the one benefiting from the whole effort while still being part of our communities. So that's the future, and we want to change that. We're working with the CMS. We're actually, next week, we're meeting in DC with the administration to make this happen as part of the pledges for really, and not calling craziness here, but make America health tech again. I know it sounds odd, but it's, this is open, bipartisan, I may say, because about patients. We can do it federated and safely, which is the way that we're going to deploy it. And AI is not your doctor. We still call the answers. We still do the prior auth. We still hug the patients. An algorithm is not going to do it, no matter what people say, because we have spent so many, millions of years nature has spent in making us humans and giving us the ability to just looking at the eyes of someone and understand that something's wrong, that a machine will never be able to do, at least for the next 100 years, unless we develop a quantum machine algorithm focused just on empathy. But we can relinquish tasks to AI, and we can take over on the things that were the best. So that's called the mode of X paradox. So we reflected some of this with the Google team in GM AI just this year. So for us, it's easy to be empathetic, bedside communication. We can do dexterity, and we can relinquish a lot of data things to AI, and we can keep the human element. So mode of X paradox is always part of the way I look into this. If you want to learn more about this, we have an educational book in ASCO that we just published this year with different folks from the space that are very focused on AI as well, not counting, someone's brother here, who's also very interested in AI and is a good friend of mine, and read his book, he's good. So I don't get any royalties for his book selling, so just saying. And some NIH things that are happening as well. So this is not futuristic, it's actionable now, it's just a matter of collaboration. We just need to work together to make all these opportunities happening for our patients and beyond. And with that, I always finish with this image of the Teatro de Spécial, who's one of the first AI-generated images that won an award without people knowing, because it tells me this vision of beauty of humanity and our arts and things that are completely just ethereal and just belongs to us as humans, but it opens a space that is kind of broad and a world possibility. So this image always evokes that on me, and I always wanted to share it with people. And with that, I thank you for your time.
Thank you very much for such an fantastic presentation, and we are learning from AI, and this is a good summary of what is coming in the future. In my clinic, 2 points. In my clinic, I'm using Abridge as well as open evidence, and it has been very helpful. I think some of my teachers are here. We need to include basically in oncology training program how to use AI, because for a long time we were struggling how to use the best way. And another point, we had a patient actually a year ago, which I shared with Dr. Lemming and Andy. Actually, that patient was carcinoma of unknown primary with CHEK2 mutation, and there was a lesion in the skull for almost 5 years. We did a biopsy. We could not reach a diagnosis. Anyway, we sent a test to KRAS and then biotheranostic, and both say 99% predictability that it's the breast cancer because it was ER/PR positive. But AI cannot replace a human being. And there was always a doubt in my mind because we did MRI, we did everything, and it did not fit like clinically into the breast cancer. And my program director, Dr. Sharif, is here. I thought if this patient go for a second opinion and I diagnose this patient as a breast cancer and he diagnosed it with a skin cancer or something else, then it will be very embarrassing. Anyway, I sent it to Dr. Lemming. So just, to appreciate, he took hours on that. We discussed, and then I called the pathologist at KRAS that say it cannot be a breast cancer, So he said we don't have enough data for the skin cancer. That's why it is coming as AI. Their AI algorithm was diagnosing it as a breast cancer. So this is just one example. We are presenting this case next week in our cutaneous malignancy conference symposium here, and hopefully to publish that we have to use these AI tools with caution.
Absolutely.
So I always tell my patient in my clinic that when I use the ambient Abridge, I said we are using both artificial and natural intelligence to come up with the best plan for you, but there is always room for errors.
Oh, yeah.
Thank you very much.
With the AI, my paradigm for a while has been it's like another tool. I heard it was a lecture by the guy that's the head of NVIDIA recently. I think you probably heard his lecture, but his paradigm I thought was interesting because it fits with what Dr. Khan was saying too, is that instead of, he adamantly was saying that AI is not a tool, it's a new way of thinking, which I think when you embrace it like that, your paradigm of approach to AI changes in a whole another way. In a I don't know. It's different. So because like when in teaching people, I always say it's not how much you know, it's how you think. That's the important thing. You can always find the data, but it's how you think. So AI really is an innovative, expanding method of extension of our thinking. And I think that's another way to think of, to embrace it that is probably more real than at least the way I was initially thinking about it.
Yeah, no, and I appreciate that comment. So, yesterday last week I was in the Google AI Cancer Symposium. It was basically kind of the same token. We can use it as a tool to extract information. I mean, that's why the open evidence there and all that stuff. But I think that the way to think about it is like, can we use these agents to be, we have the co-scientists now helping us to be like, as he was like a postdoc helping us in the lab. Can we use the same as a co-fellow that can help us to be in clinic more efficient, and still we teach the algorithm to be around the way we practice, so they also have the same alignment and humanistic approach that is important. That's what we need to be part of the discussion and not just end users of the whole process. Otherwise, we won't be part of the final opportunities there. So I agree with that.
So a couple of comments. Again, I fondly remember you from UM as well. first of all, yes, as Dr. Lemming said, it is a tool, and I think those who refuse to use the tool, like people who refuse to use GPS, will not get most places on time. But this is a tool that is capable of replacing the operator of the tool. So GPS was okay, it was helpful, but now there are fully automated cars, like Waymo in California and Arizona. You see a car going without a driver, taking people places. That did happen. It's not a fantasy, it's here, it's reality. Similarly, one thing didn't come up in your talk was a decision support tool as a use of AI. And I want to mention that I've been working on that for 5 years. And we had faculty from famous places like Dr. Pegram here today, he's on our faculty. And they made decisions on complex cases, like 500 of them. And we had the PowerPoints that we showed them. We had their output in bullet format in PDF. And using that as a control, we recently put 50 complex cases in AI. And we were stunned with the decision-making capability of AI in complex cancer cases. In fact, that's a poster at San Antonio in a month. Mm-hmm. Another one at ASH in a month. We presented one at ASCO Quality, and 2 are coming up in ASCO GI-GU. So I think that the tool is threatening us. It's here. And the sooner we get with the program and make it subservient to us rather than replace us, better off we will be.
Yes, no, absolutely, MJ. So I appreciate also as a friend as well. And I learned from you a lot of things on thoracic and stuff and entrepreneurial side, so I appreciate that too. I didn't include by design the decision support because it's such a contentious point, right? That when it gets distracting, it's better for the discussion. Right? If I put it there, it was like, oh, but I'm better than the AI. We are as humans, we take, rightfully so, pride in all the time and spend that we did for our training. But then we have an AI tool that says, yeah, no, you solve the same questions as you did with algorithm, 2020 hindsight, right? And then we get defensive, right? So I think that I agree that we need to find the frameworks, regulatory-wise and workflow-wise, that work for us, so we don't feel that we're getting replaced by this, which certainly it can be if we allow it to be, right? So that because this killing is real, if people just become fully dependent and say, oh, I only use open evidence. No, I said, no, you can see me online. I was like, no. Open evidence is nice for prior authorization, to put in things, but I'm still making the decision. It's my brain, is not, the $600 million they just put in there that's gonna go to private equity and make money out of me as an user because they put advertisement on top of all this, right? So, and the good news, this is not the CME part of it. I agree. We need to be human in the loop. We need to be the ones who dictate when we use this, and when we start seeing that this is not helping us to achieve our goals to be better in front of the patient, just trying to push us into another direction, then we need to come together and say, okay, you operate on the patient. Go ahead, get the robotics. So when I see Larry Ellison from Oracle, who I admire heavily, but I don't have the agreement on him and saying, oh, I should just get robotics. Well, he may think in Da Vinci, yeah, there's still someone you operate in the Da Vinci. Right, so it's not random robot doing it on its own. So when they get neurosurgery by a Da Vinci robot completely autonomous, okay, I get it. But I know that that's not going to happen for the many years from now. So for the decision support for internal medicine, for oncology, we need to be the safeguards of that. So I invite everyone to be part of that, but learn from it and adapt it to our benefits. Yes.
First of all, thank you for a very exciting talk. The one thing which, with perspective to the Gen I in the cancer treatment, how the clinicians and the researchers make sure the AI has been trained on biased data sets. The other thing is that as a human being, as a people serving the humanity, what safeguards and frameworks need to be in place to make sure the AI recommendation is ethical when it comes to the patient care. The reason why I say that, because the study you have shown in ophthalmology, AI predicting for 10 years for hematology, to my knowledge, there are very few data sets available where we have retinal imaging with 10 years hematology outcomes. And AI is all about algorithms and data sets. The inputs define the outputs.
Yeah, and as we say, the garbage in, garbage out, that's very true on what we're talking here. So that is precisely what a lot of these tools need to be validated on some form of clinical trials, so we can check the intervention. And we have to take into account also one important part, which is model drift, right? As we incorporate the models into our daily practice, that also changes how the model is no longer the same, right? So if we change as humans, then you're taking me into account based on a baseline that is now affected by the same intervention, then we have to create a new model that aligns to that. So this concept of model drift, we haven't really solved it. And I think it will take, probably as I mentioned, another machine that understand that to be able to determine, okay, the model change have enough variance now that that is no longer applicable to this population. Let's clean it up and run it again until we have the next version. That's why, for example, to me, clinical trial is an easy case because that doesn't have a lot of changes, right? It's objective, you're eligible or not, right? It's objective data. But in things that are more prognostic or is more difficult because in this case, radiomics, they're based on a specific intervention, which is breast cancer, ER/PR positive with a CDK4/6 inhibitor treatment. What if we now change and say we're not going to offer CDK4/6 to that patient? What's the next step for that patient, right? If we're not going to offer that, we're going to give a chemo. What are we going to give to that? And we don't have that answer because we haven't got to that place yet. So there is something called it's called causal machine learning, which is a new emerging field in AI where we're able to do the what ifs and try to develop those algorithms in a more robust way, running in a kind of in parallel. But that's very nascent. I'm working on that right now, and I still kind of say, okay, it's going to take us for a couple of years to get there. And pharma companies are doing as well. So the answer is we are not ready yet for any of this. For decision support in terms of interventions, for decision support in terms of tumor boards and discussion what's next based on the current knowledge, 100%. For things that are more heavy lift, is that, don't take this chemo or this targeted therapy or you're not going to benefit from immune therapy yet, it's going to be hard because it really needs to be validated for that very unique set of patients with the right biomarkers, and we can really predict that. So we have to be extremely objective. So all these different tools are going to be laser focused. They have to be approved that way. Otherwise, there will not be validation to prove that that's going to help you. And then with algorithm concordance, which is like we come back and say, yes, the algorithm told me so, that's why I did it, then it may come liability. And we're the most litigious country in the world. So that's why I'm saying like the replacement of physicians is overhyped. Because, okay, go ahead and sue the algorithm because I'm just following that algorithm that approved that. That's why I don't feel there's going to be any major changes on that, no matter how much you read on social media. So bottom line is we need to have these pre-screening hubs. That's what I mentioned in that we need to have this collective effort that we, in a federated learning manner, which means that we preserve privacy. I know people love that. It's okay, people can have my genomics. What are you going to do with that? Yeah, you want to know I have a mutation XYZ. Okay, what are you going to do with that? Go ahead, take it. If it's going to help the future, go ahead and do something meaningful with it. It's like me being an organ donor. Yeah, I'm dead. Okay, take my retinas and do whatever you want to do, like corneas, whatever you need to do. And my kidneys, same. So I think we have to do the same with data and being open about it in a federated learning fashion so we feel that we're still protected and there's no nefarious uses of them. But at the same time, we understand better the concept so we can really deploy the algorithms where they're supposed to be. And we have full explainability, the ability to know how we can generalize this to me because the data was trained on me and I can use it further. So more to learn.
At the risk of sounding like a dinosaur, there are a lot of variables that go into our decisions about how to best help the patient. And some of those factors are not necessarily directly related to their disease. It may be other diseases that they have. It may be other medications that they have. It may be their support system or lack thereof. It may be their ability to have transportation. It may be their insurance status or their ability to afford certain therapies. I mean, how do you rationalize all of that in an AI context?
So 100% on that. I agree on all that, and that's probably what I was alluding to earlier in the comments on the challenge trial, right? Is saying, okay, if we're going to have all this GLP-1 coming up, and they're going to be a confounding factor, and it's going to be ubiquitous and impossible to predict, and then that may impact the benefit of the exercise because maybe we need to exercise plus GLP-1 or we're not. That happens just now, even without AI. So the concept of confounding variables is something that is already part of the whole algorithm decision-making process. The key thing is to make sure that we understand, like, there's a lot of emerging things that we don't even knew they were part of the decision-making support. So, for example, when we look at these, random collagen fiber distribution in breast cancer, we never were thinking about it. Like, why would I think about distribution of collagen? Like, who cares, right? Now I do care, but at that time I was like, oh. So I think we need to have this combination of repository of emerging things that are impacting the output of the algorithm, and have them as part of the discussion and the cohort decision-making support of the whole thing. And also have some leeway in terms of variability, because nothing's going to be 100% for a number of those things. Because, once again, social determinants of health, exposomes, things that are happening on a daily basis, that is what drives the model to have the model drift, which is not just accounting for the objective data that we're analyzing on, but the other things that we didn't know were part of that, changes. So that's why I feel that two things, the large perturbation models and the causal inference models, combine them, is going to give us a little bit of an answer, probably 90% of what we need to get to be confident that the model drift is not having too much weight on what we are trying to discern. So that's why I think that a lot of things are going to be very utilized. Is going to be things like fractures in the bones. Okay, yeah, you cannot fake a fracture, right? But things that are more, complex, multimodal, is what we don't have enough information. And even the largest models in the world have any of that. Even the UK, which has so much information. So we're going to learn probably from the UK, maybe from China, they keep doing what we're doing. So let's see.
Congratulations on what you're doing with the clinical trial piece. That's huge. We have some research coordinators here who's going to really appreciate that. I mean, that's going to be huge for them and for our teams. I don't know if we have any patient advocates in the room, but I think sometimes they get left out of this conversation, right? We're all about this cool new science and what we're doing. How are you counseling your patients today in the clinic? Somebody who's there and say they saw their PET scan or whatever and they have no idea what it says, yet they could easily put that in the ChatGPT and get a very nice, for the most part, a very accurate representation of what I would have told them if they came in. They could have done it on Friday, I didn't see them till Monday, and they suffered the whole weekend because they got the result in Epic before I could release it to them. How are you counseling patients today on what to do in that situation? Is there any particular advice that you give to your patients?
Yeah, so it's inevitable that people are going to go to Dr. Google or now Dr. GPT or Dr. whoever is going to be using LLMs. LLMs are completely commoditized, so you can even run a large language model now in a computer. So you download those models from Gemma from Google. You can run in my computer. I can run it. Actually, I'm running something now on one of those. The first thing I tell my patients is, first tell me what you're seeking online. Please let me know, being open and transparent with me, because this is the same concept we're talking earlier about, like these new drugs or new things that people think are panaceas. So, the ivermectin and mebendazoles drive me insane about it. But as we said, we cannot change that mindset. They're seeking for hope and things they can control, and trying to find them online or with people they know is the way us humans feel comfortable with the reality of a cancer diagnosis. So I empathize 100% with that. But what I would tell them is, okay, listen, so let's use this collaborative intelligence together. And if you seek something online, I can tell you why maybe the prompt wasn't right, or maybe how we can look into this together, and just be very open about it, and don't be defensive about it. That's why I tell my folks, and because some of my nurses say, oh, you're looking online. I was like, sure. But let's not be defensive about it. They're going to seek it anyway. Let's just make it open for them to share with us what they were looking, because maybe the prompt they're asking was wrong. Many of my patients don't understand sometimes they think that they have bone metastases, they have bone cancer, or that they have 2 cancers. I was like, no, let me explain that to you. And the health literacy is so variable that also the questions that they're going to do to those algorithms are going to be equally as, good as bad as they can understand their disease. So that's my advice to them. Actually, I'm trying to work with some advocacy groups. So for those who are I work with Colon Town. On Monday, I'm going to give a webinar. So for any patients who are interested to learn about from the patient perspective, I'm going to be giving that at 3 o'clock. But it's also available offline. So if you want just to share with your patients, it's not just for colon cancer. It's more broader as well, but just to have the conversation. And I know I'm like okay. Like this to digest this information, and that the final punchline is there's so much opportunity here. We need to work together to make this meaningful for ourselves, our families, and all of our patients. I think there's a good way to do this, and the sky's the limit for these things now. So hopefully we can eradicate cancer for the better. That's why I say, yeah, sure. If ivermectin work, I'll give it to everyone. Give it to me. I'll drink it, right? So. That's what we're here for, right? Many of us that we did it because of families or personal reasons. Mine included. My brother had leukemia and he passed away from it, and that's why I became super passionate about Hem-Onc. So all of us are fighting for this battle. So let's show them that we're here on their side. That's the message I give them. Right.